بسم الله الرحمن الرحيم. صباح الخير. دايما بتيجي اللهم ديمها نعمه واحميها من الزوال والشباب قوه. يمكن الصوره دي بقالها دكتور عبد المنعم هنا ولا الصوره دي since a long time maybe دكتور 99 2000 14 years. Once upon a time when I was young, we began here. This is the first course here. The same. This was there, and this is Dr. Abdulmanan Sheikh and me. And definitely we began here, and we're very proud that it was the first course in Saudi Arabia to be done together. And definitely after that, Dr. Zahran and the co-workers and the team began to grow in Jeddah and in Riyadh and in Dammam. And regarding anatomy, usually we have to consider anatomy. Without the anatomy, you may get lost. Unfortunately, if you do not digest the anatomy and you don't know your way properly within the Simon-Nasal framework, you may get lost. Unfortunately, our neighbors are no more than the eye and the brain. So you may get lost either into the eye or into the brain, with definitely a big damage, and this may definitely lead to a disaster. And according to anatomy, in fact, the osteometal complex is one of the most important parts. The osteometal complex is nothing but the anterior ethmoid middle meatus complex in the CT and in the diagram. And usually we concentrate on the bulla. The bulla is the bulla. The bulla is the core. The bulla is the maidan. The bulla is the war. We can relate everything to the bulla. The answer process is located anterior and inferior to the bulla, and the fovea ethmoidal, the roof over the ethmoid, and then we have the basal lamella behind the bulla. So the bulla is the core, the bulla is the center, the bulla is al-maidan, the bulla is the dawar. The answer inferior and anterior to the bulla, the fovea superior to the bulla, and the basal lamella behind the bulla. The bulla is the bulla, the bulla is the core, and we have the agar cell. The agar cell is located anterior and superior to the answer process. And then we have the medial terminal. The medial terminal covers the osteometal complex. If we remove the medial terminal, we definitely uncover the osteometal complex. The medial terminal covers the osteometal complex, and behind the medial terminal we have the posterior ethmoid air cells. The basal lamella is the landmark between the anterior ethmoid and the posterior ethmoid. And then we have the superior terminal. The superior terminal, although it is tiny and small, but it's a very important landmark and very important structure. And we have to understand that the sphenoid sinus is located not only behind the posterior ethmoid, but also below. So whenever you want to visit the sphenoid sinus via the posterior ethmoid, always inferior and medial. You have to feel that you are going to slip into the sphenoid sinus, never ever superior and or lateral. The osteometal complex, the bulla is the bulla is the core, the bulla is the center, and accordingly we can locate the frontal sinus osseum at the bulla answer angle, anterior, superior. Whenever you want to locate the frontal sinus osseum, always the bulla is there, the answer bulla answer angle, anterior and superior. If you want to locate the maxillary sinus osseum, the maxillary sinus osseum is located at the bulla answer angle, posterior, inferior. The bulla answer angle, posterior and inferior. And then the door, we have the door here. This is the hiatus semilaris inferior between the bulla and the answer process. And then we have here the other door between the bulla and the fovea. The bulla and the basal lamella. This is the hiatus semilaris superior. Not only this, but we have here the room, the cavity, the infundibulum. The infundibulum is the space between the bulla ethmoidalis and the answer process, the door of which is nothing but the hiatus semilaris inferior. So the room is the infundibulum, the door is the hiatus semilaris inferior. And then we have here the frontal sinus recess. When we go anterior, superior toward the osseum, we can locate the frontal. It is up there toward the bulla, answer angle superior and anterior. And then we have here the other room behind and above the bulla, the lateral sinus of Grunbull which is divided into the suprabular recess. The suprabular recess is nothing but the space between the bulla and the basal lamella, and the retrobular recess, which is nothing but the space between the bulla and the basal lamella. Anatomy. One should be aware of all these structures, because if you do not understand these topics or item, you may get lost either into the eye and or the brain. Anatomy. Dry skull. This is the medial termen, the first part of the medial termen, the second part of the medial termen, and the third part of the medial termen. And we have here, this is the bulla ethmoidalis and the posterior ethmoid. The basal lamella between the anterior ethmoid and the posterior ethmoid. We have here, this is the attachment of the answer process. And then we have the agar cell here. And then we have here the hiatus maxillaris, within which we have the maxillary sinus, low fontanelle area here, this bone. And then we understand that this is the frontal sinus also. Anatomy. And then this is pharyngea cadaver dissection in Cairo University. And what we did here, this is the bigger mega inferior term. And then this is the middle term. What we did here for the middle term, we just inverted the middle term to expose the osteometer complex. And then we have here the tiny inferior superior term. Here we are. And then we have the osteometer complex, the bulla ethmoidalis, and then the answer process, and then the infundibulum in between, and then the lateral recess behind the bulb. And then this is the maxillary sinus ostium proper, and this is the frontal sinus ostium proper. Anatomy, the osteometer complex again. And then we understand that this is the answer process, and then we have here, this is the answer process, and this is the bulla. So this is the door, this is the hiatus seminaris inferior, and this is the infundibulum. And then we have here again, this is the hiatus seminaris superior and the suprabular recess of the lateral sinus. In the diagram here, we have here again, this is the answer and the bulla. This is the hiatus seminaris inferior and the infundibulum. And this is the hiatus seminaris superior and the retrobular recess of the lateral sinus. Anatomy again. We understand that this is a diagram, this is the answer. Behind the answer, we can expect the bulla. And accordingly, in the cadaver dissection, this is the left side, septum, middle termen, answer process. If we inside the answer process and remove it, if it is removed, we will expose the bulla. The bulla is located behind the answer process. And here we are, and again, this is the answer process and the bulla. Anatomy. Here we are, and this is what we are going to expect to be done today. This is the answer process, and this is the bulla behind. We can locate the space between the answer and the bulla, the infundibulum, and the door in between the hiatus seminaris inferior. And usually we begin in the middle, and then we can proceed superiorly or inferiorly according to what we are going to perform. And then we can remove the answer process. We can expect the bulla ethmoidalis. We get a bigger window. Here is a small window into the infundibulum. Is a bigger or large window into the infundibulum. And then if we remove the whole answer, we can identify the bulla. The bulla ethmoidalis is located behind the, and then we can locate the maxillary sinus ostium. Utilize an angle telescope at the bulla answer angle. Posterior, inferior. Anatomy here. We understand that the frontal sinus ostium is located at the bulla answer angle anterior and superior. The maxillary sinus ostium is located at the bulla answer angle posterior and inferior. Not only this, we understand that the way we can locate the frontal, and that the way we can locate the frontal, and then that the way we can locate the maxillary sinus inferior and lateral, never ever superior and lateral, otherwise you may get lost into the orbit. And then we understand the fontanelle, that we understand that this is the answer and the bulla. The medial wall of the maxillary sinus is not all bone, part of which is nothing but membrane. So nasal mucosa and maxillary sinus mucosa. In front of the answer, anterior fontanelle. Behind the answer, posterior fontanelle. Always, if you have an opening in the posterior fontanelle, it may be the original or the main ostium or an accessory ostium. But here we are, if you have an ostium inside the anterior fontanelle, always it is an accessory ostium. The main ostium is always located behind the answer process. Anatomy. This may be accessory or the main ostium depending on the mucociliary period. And usually we widen the ostium either anterior or posterior according. And this is just for academic interest. Here we are. This is using the light biting forceps, and this is transcanine showing the the backbiting. Usually you avoid this because the possibility of an insult to the nasolacrimal, but be careful. Be careful. And that's the way we can widen the ostium, the same cadaver posteriorly, using the through cutting forceps, which is a very common happening and needs to be done. Or we can utilize the backbiting whenever we are planning for a relatively bigger ostium. In itis, usually very small opening. In polyps, bigger. In allergic fungal size, bigger and bigger. Indefinitely in inverted coloma median mesolectomy, and that's the way we perform the median mesolectomy, the median meta-antrostomy. And then, whenever we want to visit the bulla, usually be careful, inferior and medial, never ever superior skull base, never ever lateral the orbit, and we can remove the bulla. Mind you, the frontal recess, Dr. Said stressed on the frontal recess. The frontal recess is nothing but the space between the agar cell anteriorly and the bulla posteriorly, the space in between. Once upon a time, it was called the nasolacrimal, the frontonasal duct or the frontonasal duct, but now not anymore. This is the frontal recess. And here we are. If we have a relatively moderate sized agar and moderate sized bulla, we have a relatively moderate sized frontal recess. But if we have a tiny agar and very small bulla, we have a capacious frontal recess. But if we have a relatively big agar and a huge bulla, in such a case, we have a very slim space in between for the frontal recess. It looks as if it were a frontal nasal duct. Anatomy. Here we are. This is the anterior wall of the frontal sinus, the posterior wall of the frontal sinus. Here are, this is the frontal sinus proper. This is the frontal beak, and this is the agar cell, this is the bulla. Accordingly, here we are, this is the frontal recess, the frontal ostium, and the frontal sinus. Anatomy. One should be aware of the anatomy of the area, otherwise he may get lost. And the lamellae, we have the lamellae. Here we have here the answer processing. Here we are, this is the anterior wall of the bulla, and here we are, this is the basal lamella, and this is the face of the spheroid. Again, in the sagittal cutter, here we are, we have the answer process should be expected. Then the face of the bulla, then the basal lamella, and then the face of the sphenoid. And again, anatomy, the parasagittal cut, whenever we have it, is perfect because we can locate the answer. We can locate again the face of the bulla, and then the basal lamella, and then the face of the spheroid. We have to expect this strata, especially during cadaver dissection. The anterior ethmoid artery and the roof. The roof, whenever you want to perform this, never ever not to be able to clearly identify all the structures of the skull base. And here we are, we have to be aware of the crista galli. Here we have the crista galli. And then we have to locate the nasal septum. We have here the nasal septum. And then we have to identify the middle termen. We have here the middle termen. And then we have to locate the cribriform plate. Here we have the cribriform plate. And then the very slim, tiny lateral lamella. We have here the very slim, tiny lateral lamella. And then the relatively thick frontal bone. Here we are, the fovea ethmoidalis. We have here the relatively thick frontal bone, fovea ethmoidalis. And then the thinnest part of the anterior ethmoid artery. The thinnest part of the anterior ethmoid artery. And then we have to identify the relative height of the fovea in relation to the relative very low cribriform. And mind you, one should be aware and avoid, sometimes you want to remove, sometimes you want to remove the polyps, remove the polyps, remove the polyps. Well done, well done. And then you go immediately remove the polyps, and then this is the level of the fovea. So we remove the polyps. Remove the polyps here are nothing but the brain. We have to be very careful. So the level should be well studied. And then after that, we can understand that we have here relatively very thin lateral lamella and relatively thick fovea ethmoidalis. And then the level, the cribriform may be the lateral lamella up to 3 millimeters, up to 7 millimeters, up to 13 millimeters according to the care specification 1, 2, and 3. So one should study the CT beforehand and make sure that the right side is right side and the left side is left side, because you see the difference. In both sides, they are not identical. And the roof should be the fovea ethmoidalis, the supraorbital air cell, the frontal recess, and the anterior ethmoid artery. And we understand the direction of the anterior ethmoid. Whenever we want to discuss the medial termit, the medial termit should be well studied. And we have here the first part of the medial termit, the second part of the medial termit, and the third part of the medial termit. Can you have just a sheet of paper, please? Sheet of paper. Just a sheet of paper. Okay, can I take this? Because this is not, I want to let's see. This one. واحدة بس. empty. واحدة. أي piece of paper. Okay, 3 minutes left. Usually because he told me 20 minutes left. So 10 to too much. So whenever 5 minutes, okay. So this is the medial termit, because this is the most important part of the 3 minutes left. And this is the medial termit. Can you just put on the light please for a while? And I believe that if we understood the medial termit, this is finished. So I claim that this is my right medial termit. This is my right medial termit, and it's composed of 3 parts. This is the first part of the medial termit, this is the second part of the medial termit, and this is the third part of the medial termit. The first part of the medial termit is sagittally oriented. So it is parallel to the lamina papyracea and the nasal septum, and still perpendicular to the skull base and the floor of the nose. This is the first part. And this is the third part. The third part is axially oriented. Axially oriented. So axially oriented, it is parallel to the floor of the nose and parallel to the skull base, but still it is perpendicular to the palatine bone, perpendicular plate of the palatine bone. So this is sagittal and this is axial. How comes for a sagittal structure to be converted into an axial? There should be a vertical here. This is the coronal part. The coronal part is the second part. This is the basal lamella. So the basal lamella is nothing but the second part of the medial terminal. And accordingly, it's adherent superiorly to the skull base, and laterally to the lamina papyracea, and medially to the first part, and inferiorly to the third part. So this is accordingly. If I want to visit the posterior ethmoid via the anterior ethmoid, the best site to penetrate in here is to go inferior and medial, and here we are. From the anterior ethmoid, the bulla, here I can see the bulla, and this is, and accordingly I can go, this is the opening I begin here, and accordingly I'm relatively safe. Superiorly, the skull base, and laterally the lamina papyracea, we have to avoid this. So it is very important to be aware of the 3 parts of the medial termit, the first part, the second part, and the and then the third part. And here we are. The bulla is located anterior to the basal lamella, and the posterior ethmoid posterior to the basal lamella. And in the coronal cut, we can locate the basal lamella, and in the axial cut easy between the relatively large posterior ethmoid air cells few and the relatively very small, tiny, but a lot of anterior ethmoid air cells. But sometimes we are confronted with this. It's difficult because of the pathology to identify which of which where is the basal lamella. And that's the way the first part of the medial termit, the third part of the medial termit is located there axial. This is sagittal, and this is the basal lamella proper. And here we are, the first part, here we are, the second part, here we are, the third part. And according the basal lamella, after removal of the bulla, this is the skull base. This is nothing but the lamina papyracea. This is the first part, and this is the third part of the middle term. And whenever we want to go into the posterior ethmoid, always inferior and medial, always inferior and medial, and then we can widen that and get into the posterior ethmoid, identifying the important superior terminal. And then you have to understand that the skull base is not axial; it is oblique. Accordingly, the possibility of an insert to the skull base is there. So never ever to visit the sphenoid sinus, superior and lateral. You may get into the brain, always inferior and medial, and that's the message. And the skull base of the posterior ethmoid is relatively flat, not like the anterior ethmoid. We cannot see where is the crista gallic finished, lateral lamella finish, and so on. But the optic nerve is too near, so the orbit is a relatively bad situation. And the same caliber, right side, whenever you want to visit the posterior ethmoid, be careful. You have to identify the relatively white skull base, and then the relatively yellow lamp breccia, and then the relatively pink bulging face of the sphenoid. This is the angle should be respected, and you can go into the sphenoid sinus. And here we are. This is the superior terminate, and then again, whenever you are inside the posterior ethmoid, be careful. You have to define this rectangle, the skull base, the orbital apex, and then the third part of the medial terminate, the superior terminate. And you can draw these two triangles, the red triangle, superior and lateral. The green triangle is the inferior and medial, where we can visit the sphenoid sinus in the, again, the anterior ethmoid artery located at the face of the bulla. The posterior ethmoid artery is located at the face of the sphenoid sinus. So one should be aware of this. And whenever you want to locate the anterior ethmoid artery, is it within the bone, like here, or within a mesentery here? We have to identify the media rectus, superior oblique, and then the nipple. And here we are. This is the anterior ethmoid artery in a mesentery. Here it is in a bone. On the contrary, the posterior ethmoid artery is located in most of the cases within the bone. And the direction of the artery is quite different. The two posterior arteries are like this, and the two anterior ethmoid arteries are like that, from posterior to anterior, from lateral to medial. Whenever you want to visit the posterior ethmoid, you understand that superior terminate is very important. The superior terminate in here, and this is the septum, this is the middle terminate, and this is the superior terminate, left side. And accordingly, if we went between the superior terminate and the middle terminate, this is the posterior ethmoid. If we went between the superior terminate and the septum, this is the sphenoid sinus ostium. And that's the way we usually go into the posterior ethmoid, or that's the way we can visit the sphenoid sinus transnasal. If you fail to identify the ostium, always go to the posterior wall of the sphenoid, the nasopharynx, and then the roof of the nasopharynx to the quana, and then the anterior wall of the sphenoid, and then locate the ostium. The foramina, optic, carotid, the V2, the median, and the palatino-vaginal should be well studied, and have a lecture like this. If you want to visit the sphenoid, either transnasal or transethmoid, and here we are. This is the transethmoid or the transnasal, and be careful of the optic nerve and the carotid arteries. Here we are, and according, I just want to finish. How many minutes do I have? Okay, 1 minute. Thank you. I just want to invite you to Reign Egypt 21st. We have an annual meeting every year. Thank God, this is alhamdulillah العيد بتاعنا ال 21. So hopefully everybody will be there. And don't forget, inshallah, we have in Dubai this January our meeting with Dr. Hussein Abdurrahman. Thank God it will be a big meeting as well. And then don't forget Brazil, the big IRS meeting in Brazil with Aldo Stam. So we are inviting everybody to go there, and we have to have a very big gathering. And if you have our 6 parts, inshallah, next year in Saudi Arabia, in Riyadh, Dr. Amri and the co-work, Margalani, وطبعا زهران, the team taking care of this meeting. And we have just finished our Asian IRS parts, which we have عندنا نكافح 6 سنين كاملين عشان نعمل الميتنج بتاعنا في دبي، واللي كان في شرم الشيخ، وربنا اراد ان احنا نقلنا دبي. It was a very big meeting, alhamdulillah. It was a very big meeting, and we had a very good gathering from all over the world. The attendance was remarkable, 1600, and we had a very good definitely friends up there. And in conclusion, we have to be aware of the anatomy to perform safe and effective surgery. To go to the first situation, we began here, and ربنا يدينا الصحة والعافية to end here بإذن الله. والدكتور عمنا جاء عشان ما حضرش أول صورة، بعد جبناها تاني. شوف الشباب والشعر الجميل. لا إله إلا أنت سبحانك. شكرا لك.
Can I ask Professor Boykas again, who will join us in the instrumentation, and Professor Aiko Mugalla, together with Professor Ahmed. So just we'll have a very important part of the course, that is the instrumentation hand-on. Our guest professors, they will give us their experience in dealing with instrumentation and maybe positioning observation, just to have an idea for doing the same.
My wireless. Wireless, where is it? Wireless.
If I can start this part by giving each of you their experience in doing how they do the same regarding the positioning of the patient and sitting, standing, because there is some confusion for the especially the new kind. So may I ask you, Professor Tiziano? Sure. Where is the other mic? Can they bring it? Yes.
Well, certainly in the 26 years that I've been on faculty at the University of Miami, things have changed considerably as far as rhinology, of which those 26 years I've been doing rhinology for 24, something like that. And certainly as far as technique and teaching and curriculum, it's changed as we've changed, as technology has changed. When I first started doing it, we used to have forceps that didn't cut. It was just, those of us who remember, just grasping and very destructive. And as you well know, the whole concept of doing modern day rhinology and sinus surgery is preservation of mucosa where at all possible. However, I have to tell you that not all patients are possible to preserve mucosa, particularly in revision cases, particularly in some polyp cases. But the new generation, as time evolved, we started having instruments that cut and preserve mucosa. And then, of course, in the mid-1990s, we got into the powered instrumentation. And truthfully, I use very few instruments other than a powered instrument and maybe some probes and an occasional forceps to pick up the little bone. Again, with overall goal of trying to preserve mucosa, particularly around the frontal recess, if anything else. And then, of course, we've evolved into now endoscopic skull-base surgery. It's a completely different topic that we'll be reviewing in a couple days. And there, we take the hat off of a rhinology and we put on the hat of an oncologist, which is totally different. There, we don't really care about the mucosa. There, we care about three-dimensionally removing tumor. So that's a different issue. So as far as the instrumentation, I even from the start, I never really used 0-degree telescopes that much, and I rarely used. I never sat down and looked through the microscope or through the telescope. I always used monitors. Back in the first day I did sinus surgery in 1989, I just felt that very uncomfortable. I wasn't an otologist. I was trained more as a head and neck surgeon, and head and neck surgeons aren't that patient to sit down and sit there like an otologist and just work with a microscope. Just don't have that patience. So the fact is that it also was bad on my neck to be sitting there through a telescope. So I felt that my neck has gotten a lot longer longevity by working comfortably from a monitor. And of course, that's improved too with high definition. Now, I don't care much for the 3D yet. The 3D goggles make me dizzy. after I use it for a while. So that's nice pictures, but from a 4 or 5 hour cases, they're uncomfortable. So I usually use the 30-degree telescope as the workhorse, both in the operating room and in the clinic. Remember, we have pretty much similar instrumentation in our clinics that we do in the OR. We do a lot of in-office procedures nowadays. And then as far as the forceps, the main ones I use are going to be the medium size, depending whether you do adult or children, but mostly let's talk about adults. Even for adults, we use the medium sized forceps, particularly the straight and the up-biting, non-through and through cut. So sometimes there's a point of having forceps to grasp, so you want to remove tissue, so you use the non-through cut. Other times you want to cut and you want to sharply cut, and you use through cut. But again, most of the cutting I do with power dissectors now. They're very aggressive, very sharp, which is a double-edged sword. You got to be careful because you can quickly go into the orbit and have a complication. But they're very, very quick in the way that we do the surgeries. A typical bilateral extreme polyp case with septum and turf generally takes us no longer than an hour and a half to do. It's a very quick surgery. So they go very quickly. The giraffe forceps, the longer ones, we generally reserve those when we're already in the cavities and we want to grasp and work up high or out laterally to grab equipment. So those come in 70, 60, depends on the company, some 110. The suction tips are very important, the curved suction tips and the Fraser suction tips. I tend to use more of the 4mm ones because they clog too quickly or be too thin. We do not use suction tips to probe and to enter sinuses because all you do is traumatize the mucosa. If you're going to probe, we have specialty probes. I'm sure you have them on there with the tiny little balls. If you do somewhere, yeah, over there. I see some over in that end.
Yes, maybe we can change our position. Is this the mic?
Oh, this will be
So
better.
it will be.
That way I can point out these things a little better. And I don't want to take the glory from all the other discussions here, but okay. Okay, so I think one of the main important, actually my most important instruments. Let me see if I can get them. Sure. Oh, I like the longer probe. They don't have some of the long ones. These are kind of short because the longer probes can go.
He can here. It's a difficult course. Mumkin يقرب.
So the probes are very important. When you do surgery of the sinuses, as Dr. Kamal mentioned, you have the orbit, and the orbit is very important, and you have to get used to palpating. That has not changed from the time I was trained before endoscopic sinus surgery. As you're entering a cavity, you always palpate the eye, and you always palpate from below, from within the cavity you're entering, with a probe to make sure you can palpate bone before you remove bone. Okay? Nothing wrong to see the orbit move as long as you know that's the orbit, and you don't need to go any further lateral. Okay? But probes are very important. This one's a little short. I like the longer ones that can actually go all the way up to the frontal and go around corners. But you get the idea that probes are very important. As far as forceps, we discussed the through cuts. Here's up-biting through cut. I don't generally use the suctions that much. Some people do. And they come without suctions too. But these are a through cut and they preserve mucosa and cut. Okay? So these are the ones that cut upward, and there's some ones that cut straight. So those are the main two. And these are like small and medium size. backbiting forceps is very instrumental, not just in removing, for example, the uncinate, although again, I tend to use that microdebriders nowadays, and not so much the through cut, but if you don't have a power dissector, this is the instrument you can cut backwards. It's not just for the uncinate though. You can use it not just as a cutting tool, you can use it as a grasping tool. You don't have to close it all the way. If you want to get a piece of bone backwards, you can just grab it and then push it away to just remove a little piece of bone. So remember, it's not just a cutting tool, it's a forceps too. The giraffe forceps, I'm not going to show you all of them, but these are non-through cut forceps that are useful. These are the giraffe forceps, which are useful once you're already working up in the frontal or out laterally in the maxillary or in some recesses. These have different angles. They can go 60 degree, 90 degree, 110 degrees, and the forceps may be vertical or lateral. Some of these are even cutting forceps too. They come in cutting forceps. These are more for the finesse work. You have to be very careful with these when you're grasping bones. They break real easily. I have a mini fellowship in Miami. We have visitors all the time, and I have to remind them, you know, these things are, I don't know, how much are these now? They're expensive. They're not cheap. And so it breaks very easily. So these are just finesse work, to get little pieces of broken bone or to grab a little polyp or mucosa up in the front or laterally. But these are the giraffe forceps, okay? The other things are either the curved suctions, and they come in different suction width and lengths. So this is a little shorter 4mm suction. These over here are the 2.5, is that what you have, 2.5? And then these also come longer. I like the longer ones because you can do more with one suction. But remember, these are not to go in there and push and go into sinuses unless you intend to disrupt mucosa. If it's a case that you intend to remove the mucosa, it makes no difference. But if you want to preserve mucosa, you don't want to be pushing with these because this will elevate the mucosa and destroy it. So you want to be as sharply as possible with it. The straight brazier suction tips, they come in different sizes. Notice there are measurements. You see the measurements there? It's at 5, 6, 7, 8, 9 centimeters. There's a reason for them. And a lot of this has to do more with what you heard previously. You heard the basic anatomy for primary sinus surgery landmarks. There is also a separate group of landmarks that we use for revision surgeries because the lamellas aren't going to be there, okay? Total different topic, but one of the things we do, in addition to these other things, we also know distances. So we know that at 5 centimeters is the basal lamella of the middle turbinate, the one that Dr. Kamal talked about, okay? That horizontal portion there. At 7 centimeters is the face of the sphenoid or the back wall of the maxillary. Same coronal plane, more or less, within a couple millimeters. And 9 centimeters is the back wall of the sphenoid, and that's the only thing that's 9 centimeters. If you're not in the sphenoid and you're 9 centimeters from the columella, you're nowhere in the sinuses. You're probably intracranial somewhere. Okay? So these are useful by itself. They're okay. They're somewhat useful. You have to use it in conjunction with other things, but they're there and they're available. What else am I missing here? They have a variety of other instruments that may have cautery and may have other like, you know, you got the bipolar cauteries that can be useful. A little more useful for skull-based surgery when you're around the carotid, around the optic nerve. I tend to use monopolar suction cautery, the malleable disposable ones, pretty much for everything that's in the nose. You got to be careful when you point it and touch it to bone around the anterior ethmoid because when it chars, when you pull it off, you can pull the bone and get a CSF leak, so now you got to be prepared to fix a CSF leak. But if you keep it away from about 1 millimeter when you use it, you can cauterize it. These are the various telescopes. Like I said, I tend to use 30 degree as my workhorse. I found that for novices, it's easier, if they're going to learn on an angle scope, the 30 is the easiest one to learn because it still has the visualization of a zero with the advantage of being able to look a little bit to the side so you can see what's going on the lateral wall of the nose. The 70 is the other one we use once we want to start working and look up into the sinuses or laterally. The 45s are hard to teach with. It's difficult. It's already too angled to learn, but that's certainly an alternative. Am I missing anything here? Bipolars, everything else is pretty much just bipolar. Oh, these are just the retrograde. Yeah, here they've got different forceps that depends on the situation. These are specialty forceps. If you want to go around the corner, like in the maxillary, and grab a polyp from the front wall, they have different things that allow you to go around the corners. So it all depends on the situation. They also have the kerosene. I missed the kerosene, whatever it is. The kerosene bone ranger, do you have one here? You have that, you have this little mushroom thing. Yeah, this one here that cuts. I don't tend to use this one much because you need real thin bone to be able to grab around it and cut it, but it's the same concept. You grab the bone and you cut it, okay? They have some of these that are angled that you can use up into the frontal sinus. But it's really the kerosene that we use. That's our workhorse to open up the sphenoid. And also, we have different types of kerosenes. We have 40-degree kerosenes instead of 90-degree kerosenes when we do pituitary work to take off the cellin. They come in 2s and 3s and 1s and different sizes. Those are more neurosurgical type equipment that we've become accustomed to using too. There are scissors, of course. As you can see here, there are scissors that you can use for a variety of things. You know, whether it's trimming a turbinate or trimming a flap, raising a flap. We also use cautery to make incisions in the septum. So, I mean, those are we have osteotomes right here for septoplasty if you want to take off a crest or a spur. And sometimes when we raise the flaps, we'll use the osteotomes if it's really there. Careful not to go to the other side. You always want to raise tunnels on both sides. You all know how to do septoplasty, so that has not changed whether you do it endoscopically or not. So that's for that. Am I missing something? I'll let who wants to go next.
Thank you. Good morning. First of all, I would like to thank for the invitation. In respect to Dr. I'm coming from Italy. I was trained by Professor Castelnuovo, maybe someone of you know him. I have a little bit difference with Professor Casiano because I use very rarely the 30-degree scope. Most of the surgery I perform with 0-degree scope, and I'm used to use the 45-degree scope. I perfectly agree with him that is a little bit more complex to learn to use, but I feel that it can offer some more details, especially when you have to work around the corner. But anyway, I think it's a matter of experience. My hands, 30-degree scope helps nothing. I know a very skilled surgeon in Bologna, Ernesto Paspini, that most of the surgery he performed, he did with 30-degree scope. I was trained with 0 and 45-degree scope. There is a lot of instrument here. I feel that you have to find your way. Of course, I was trained with, I am young enough not to have been trained with not cutting instruments. When I was trained with powered instrumentation, cutting, so most of the instruments you see here, I was trained with. So I have no the experience of the previous surgery. I was trained to use a lot of instruments, now I use few instruments. I feel that once your experience grows, you are used to use some instrument. I am in love with the microdebrider, and I try to use. I'm used to perform most of the surgery with the microdebrider, but I feel that is not a good advice for beginner. So try to follow a step course in your training. The use of cutting instrument is of critical importance to avoid the mucosa damage, of course. And I'm used to work with a lot of angled instruments because for me it's not a major problem to work with a 45 degree, as I told you. and the instruments designed by thought by Professor Stamberger, the mushroom forceps in my hands are very useful. And I also use the Carizon, so the straight mushroom or the angled mushroom in my hands are very useful, especially for sinus surgery in the frontal sinus. The revision surgery is a very different topic, of course. Especially in this case, I advise you to use not sharp instrument, especially in the beginning of the surgery. Find, of course, your landmark. The use of dissector or palpation, of course, is of utmost importance. The advice Dr. Casiano told you regarding pushing the eye is, of course, one of the most important you can use, and don't fear to do this maneuver many times in your surgery, because it's much more better. And please stop when you are not sure, because especially in inflammatory disease, it's much better to stop before create damage, and not to try to the best for you could be not the best option for the patient. So take your time to get enough skilled, and even when you feel to be enough skilled, think twice before doing something, because my major complication, if I can say, is now and not in the beginning. It is, I think, the story of everyone, because you feel more confident and you do something that you feel safe, but it's not safe. So I told you before, I use the microdebrider very often, but it is not a good advice anyway, so don't follow my experience in this case. All these instruments, the OIViser is a very useful tool I use for the very angled alveolar recess when you have to remove, especially deep seated inverted papilloma. This instrument is very nice for me. But as you can see, different trained surgeon, Casanova has taught me to use 0 for everything and to do the same things in the beginning. So look at the coena, look at the middle turbinate, of course, in the same way, and then 45 to check the lateral ostium and the maxillary sinus or the frontal sinus. I feel that you have to find your personal way. Once you have learned the critical rules and think twice before doing something, but the way you use the instrument is a question of your feeling with the instrument. So please follow everyone's advices, of course. Most of experienced surgeons can give you a lot of wise advice, but at the end, summarize in your hand in your mind, what is your best way to manage the patient. I think that's
Very good morning, everyone. I'm the counterpart of Professor Kamel. I'm the neurosurgeon who's working with him. We've joined forces definitely since 2008, so we have a plan. We do a systemized way. He has a job description, I have a job description. I start from the cellar and above. So what we use here from the instruments available are the 2 telescopes, the 0 and the 30, mainly the 0, the lead 4 millimeter. Rarely we do use the 2.7 when we are far in, especially the longer ones. This is as regards the telescopes. We prefer very much going binary and forehands to use double action tools like the bipolar with irrigation. This one is a little bit longer. And unfortunately not here, the twin flow, where you can do suction with irrigation, and the suction with coagulation. These are very handy because the crowding of the instruments within, especially in expanded approaches, is an ordeal if you don't have these tools. They limit your function and your extent of surgery. What we depend on, we never use any grasping forces. We do not pull on anything. Once you're inside the brain, this is definitely unacceptable because you do not see behind. And so you have to first dissect. We call the dissectors the possible dissectors. And we use mainly the ring curettes, we call the angles and the sizes, and the suction with all the angles and the sizes. These are our main tools with the bipolar, of course. This is putting it very short. I mean, this is still the basic course. My role comes more in the advanced.
To begin with, usually we can take it the other way. When we begin our surgery, we use an endoscope. In fact, in our everyday work, and usually advise using the 0-degree telescope throughout all the work just to be oriented, especially for beginners. And we keep the 30-degree telescope for the maxillary sinus and the 45-degree telescope for the frontal. Just in case if we want to go to the lateral recess or the sphenosinus, we can use the 30 or bilateral. So in all our work, we usually advise to begin with the 0-degree telescope for the best orientation. After a while, you can use the 30-degree, but to begin with, you can use the 0-degree throughout all your work, 30 for the maxillary sinus, 45 for the frontal sinus. Usually, when we want to perform any surgery, you expect polyps. So usually, we want to remove these polyps. Usually, we have to select the best tool to remove the polyps. We can use the grasping for biopsy, and then the shaver. The shaver usually we use the serrated. This is the shaver. In fact, the shaver is the best tool to take care of the polyps. Within few minutes, you can go through the polyps toward the nasopharynx. Always we advise you have to identify the nasopharynx and then keep your suction tip up there, and then you can try to identify the inferior terminate, the medial terminate, and then the answer process. Whenever you identify the anatomy, the medial terminate is there, the neck of the medial terminate, so finish. You begin to stop the shaver and begin to take care of the answer. If you are planning to visit the lower part, the maxillary sinus, the middle part, the bulla, if there is a good reason to take care of the frontal recess according to the CT, so in such a way you are going to remove the whole answer process. If the frontal sinus recess is not involved by any disease, so remove only the lower 2/3. Just in case an endocardial polyp, there is no need at all to remove the answer upper 2/3, remove only the lower part. So the tool we usually use for the removal of the answer, the safest for us, we have whatsoever a tool, but we advise usually using the frame, the sector, exactly like I showed you in the middle, and then you can proceed inferior and posterior and then anterior to superior. Be careful not to shift laterally, otherwise you may insert the orbit. You can use whatsoever a tool. Sometimes it advises backbiting forces, but we believe that even the second knife is relatively dangerous. So you can use the sector. So now we remove the answer with the sector, and then we want to take care of the maxillary sinus. Usually advise the maxillary before the bulla. As long as you are below the bulla, you are relatively safe. The first step is to utilize the maxillary cecal. The maxillary cecal is the best way to locate the ostium. Bulla answer angle, posterior and inferior, just above the inferior terminal. Just the remnant of the answer is very good tool to guide you to the location of the maxillary sinus ostium. Always you direct your tool inferior and lateral. Never ever superior and lateral, otherwise you go into the orbit. Because you want to identify the answer, to take care of the answer, and avoid insult to the nearby structure. Identify the maxillary sinus ostium, take care of the ostium. If you want to widen the ostium, so we identify the ostium by the maxillary cecal, and sometimes we can use the curved section again. The curved section here we are. The curved section again, blunt. It's a blunt. So again, we direct inferior and lateral. Always inferior and lateral. Never ever superior and lateral. Otherwise, hoppa, you will be into the orbit. So inferior and lateral. I identify the ostium. And then we can use the through cutting forceps, the straight through cutting, or the straight through cutting. Straight through cutting. Thank you very much. So we can use, we identify that the ostium is seen, the remnant of the answer, the ostium, so we can just cut the posterior lip over the ostium. Usually that's more than enough in itis. We can widen more to the posterior wall in polyps. Just in case of allergic fungal sinusitis, we may be obliged to widen it more anterior, backbiting. We do not use the backbiting very aggressive to avoid, thank you very much, to avoid, so we can just apply the backbiting along the anterior tip and just few cut, but be careful, we have to introduce it. We can see the tip and then rotate it into the maxillary sinus and then apply it along the anterior tip and tuck and then rotate it again and get out, because don't leave shreddy mucosa. If you cut, remove it. So be careful, the nasolacrimal duct is there. So we perform it millimeter antrostomy. So if we want to visit the bulla, inferior and medial, we use the straight section. The straight section to begin. We begin inferior and medial, superior skull base, lateral lamina, inferior and medial, just a tip. Oh, we are inside the bulla. The straight again, the straight through cutting, we can use it to remove the anterior wall of the bulla. The anterior wall of the bulla, we remove it. The inferior wall of the bulla, we remove it. The medial wall of the bulla, we remove it. We can use the superior, the upturned forceps, okay? And we can use again the upturned force to make sure that we remove the whole anterior wall of the bulla. Be careful, the lateral wall of the bulla is nothing but the lamina papyracea. Never ever to remove it. The superior wall of the bulla, we leave it at the end whenever I want to take care of it. Whenever we want to visit the basal lamella, we penetrate using the straight suction again. With the straight suction. Inferior and medial, skull base, lamina papyracea, first part, inferior part. We visit it via the inferior and medial, and then if we want to widen the basal lamella, we go to the mesh room, straight mesh room. Okay. It's very safe. So in beginning inferior and medial, then lateral, superior. Be careful, the lamina papyracea, be careful, the skull base up there. So we are now inside the posterior ethmoid. We can use the straight forceps, not the through cutting. Now the posterior ethmoid very dangerous. So you can just the grasping, the Blacksley forceps, the straight Blacksley. So now we want to identify the superior terminal. We remove the posterior ethmoid air cell, relatively big, few in number. Now we remove the polyps from the posterior ethmoid and we identify the superior terminal. Now the skull base white, the orbital apex yellow, the bulging anterior wall of the sphenoid. Now we want to go into the sphenoid sinus. The first step is to utilize the dissector to be careful and to identify the superior terminal, the face of the sphenoid, the skull base, the orbital apex. We have to make sure this is the superior terminal. Keep it intact. If we want to just suck what's inside the sphenoid, just cannulation, we can go and visit the sphenoid sinus via the sphenoid recess medial to the superior terminal using the suction. Just in case, if you want to widen the ostium, there's a pathology inside, fungal whatsoever, we widen it. So in such a case, we have to amputate using the straight through cutting to amputate the far inferior part of the superior terminal, and then use the mesh room, the straight mesh room again, mesh room or the kerison to widen the sphenoid sinus laterally, superiorly. Now we perform a relatively wide sphenoidotomy and we take care of the sphenoid. Taking care of the skull base, we use the curved section again. The curved section is relatively very safe to dissect the trabeculae and the fovea of the posterior ethmoid, and then the fovea of the anterior ethmoid, and then the anterior ethmoid artery, the supraorbital air cell, and then the frontal recess. Usually you stop here with the most. We take care, identify the ostium, suck the secretions inside, and finish. This is usually the 95% of the cases. So accordingly, I usually advise you to throw all these tools and take this one only. and that's with the shaver. So I believe that's for the everyday work, but definitely whenever we grow to the advanced techniques and with the extended techniques with Professor Zohdi, definitely everything should be there, including the bipolar, including the whole set of the skull base. So to begin with, this is the basic steps we usually do, and the basic tools we usually utilize. I'm sorry for that.
Professor Kaziano, you said that you use a 30-degree scope for the middle meatus polyps and for the remaining stuff. Why use 30-degree? Why not 0?
Because I'm not an otologist. It's funny, if you look at the history of sinus surgery, it was introduced in the United States by an otologist who's used to working with a microscope, David Kennedy. Nothing against data, I love them. But if you're a head and neck surgeon, you want to see what you're seeing to remove. All the anatomy, all of the anatomy. Unless you're doing pituitary, or unless you're doing a septum, and even with a septum, an angle is very helpful to look up high and look underneath here. Unless you're doing that, all the anatomy we work on is going to be lateral. There's nothing that is straight in front of you. If you know, it's funny because we've done that. You know, there's a big difference. In the United States, our residents immediately are involved in doing cases. They don't observe, they're doing cases. And one of the things you learn as a professor in the United States is that it's a two-way road. Learning is a two-way road. It's, you know, the students learn from you, as in any other place, but the professor learns from the students. And what we have done over the last 20 years, particularly in the United States, in modifying the way we teach, not the way we do the surgery. Once you're experienced, you can do the surgery however you want. But the way we teach is based on the observations that we've made on watching novices operate first in the lab, and then watching ones that go out into practice and operate, and watching potential complications, like going into the orbit, like going to the carotid artery. We don't go transithumoidal anymore into the sphenoid, for example. We abandon that. We don't remove the uncinate in an antero-posterior fashion. We do it retrograde because we saw too many penetrate the orbit because they were trying to do that antegrade through the cut with a little sickle knife routine. So we've abandoned that, mainly in the best interest of our patients. It is a safety issue, okay? When you teach somebody to drive or drive a plane or fly a plane, you have to do a root cause analysis and find out, after you see the complications, how you could have prevented those. And when we did these, we found that we had to change the way that we taught. Once they learn, they can do it any way you want, you know, up, down, black, sideways. And it's easy for an experienced surgeon to say, I do it this way. And yes, I do it every way that you've heard it. And many times I change it the way that I do it. But the way I teach is different. The way I teach is to teach you to begin in a very, very safe way for your patients so that you don't get those complications. Because we've seen it. It's going to happen, okay? So if you hear anything out of my mouth, it's based out of patient safety. It's not because it's a religious way I do it, and I base it on just because I was taught that way. It's not that way. It's really because it is a safe way of doing it. Okay? And using 30-degree gives the ability to see.
If you comment, please, also, so why you prefer to work standing in the surgery?
Because, well, first of all, I run 2 rooms simultaneously all day. So I stair-step rooms. And I have 2 fellows and a chief resident usually are with me. And so they're doing a lot of exposure work in one room where the anesthesia is putting them to sleep while I've got the other room going, you know. So I just don't have the patience to sit. I feel it's uncomfortable to sit. I move too quickly to sit. You know, we'll do a bilateral polyp case in an hour and 15 minutes, front to finish. It's not something you can, it's just a personal preference. I just don't, and I'm not an otologist. Nothing against my colleagues. I have colleagues that are otologists. I don't have that patience.
Thank you.
Can I just add a small tip on the way we handle the scopes? I know we have extensively talked about the tools, but if you allow me just a few minutes to talk about how to handle the scope, and this is very important while we start. So I find a lot of beginners, when we start handling the scope, is extremely important. So if we start with the 0-degree scope, I will not hold the microscope, the 0-degree scope, the way we handle it, and I find it a lot of time cumbersome, is that once you hold the scope like this and the head is here, the cable will be running down this way. And then you have any instrument that you want to use, you find yourself knocking the cable and then knocking the scope and then having a kind of hesitant view. So the best way is to avoid having the cable hanging down where you are trying to use your instruments, where you're trying to use your suction all the time. So the best way to do is either put it laterally, the cable, along with the camera, or even put it the other way around. So put it from the head coming down. In this way, you will easily move your suction, you will easily use your instrumentation without having the cable knocking on you all the time. Okay, so this is very important to start. And then the other thing is to anchor the scope on the nasal pyramid and hold it upwards like that, because a lot of time beginners especially find the scope moving around and the instrument moving around and not really focusing on what you want to see. So anchoring the scope is number one, having the cable coming either laterally or coming out superiorly, while you can freely use your hand easily with your instrumentation. So that comes a problem. This is the 0 degree. Wherever you put the cable, it doesn't matter because you have a 0 degree. But that comes into a problem sometimes when you're using the angled scopes. So the angled scope, if you want to use the 30 degree, and you want to look upwards, the cable will definitely come downwards like this. And at that time, you'll have also a problem using your instrumentation, correct? So that's why a lot of people avoid using the angled scope, the 45, and find it a problem, because whenever you want to put your instrument, then your angle goes right or left. That's why they invented the reversed scopes. I'll finish the reverse scope. Reverse scope is that when you are looking this way and the angle is looking upward, this is a normal scope. The reverse scope, and it's manufactured, so if you want to, as you are going to be ordering a new instrument, and if you have the option or the option of buying new instrument, it's preferably either to buy a lateral scope or it's called the reverse scope. It's called the lateral scope or reverse scope. Lateral scope, that means this part of the cable comes out from the side. So at the same time you are working easily here, your scope is looking towards upward. And at the reverse scope is the same thing. The angle is looking upward while the cable is coming out from the top. So these are kind of just a few tips that I wanted to mention, just handling the scopes, especially beginning in the cadaver dissection upstairs.
Thank you. So actually, this is a very nice point, because I see, having a 30-degree scope, which is sometimes regular one or the lateral one, and the reversed one. Now, sometimes you ask your assistant or your nurse to give you the scope and the 30-degree scope, and he is giving you the 30-degree scope, but he's giving you the reversed 30-degree. And a lot of the times I see, at times myself or the assistants or the residents, okay, they are working now with the reversed 30-degree scope, and they are like using it this way down to see up, but they are actually looking down, okay? And like they are, it's maybe 15 minutes and they realize they don't see well. I don't know what's going on, just things are not okay, but the way it's actually reverse degree scope. And I always tell my nurse, please, whenever you are giving someone the 30 degree scope, tell him, or this is the reverse of 30, just because the routine way we are using is just to use it this way and start working from there. And sometimes take you 15 minutes to realize that. The only thing I would love, I actually benefit myself from listening to this, with curettes. I like using the curettes parallel to like the danger, I would say, the landmarks, the boundaries of the sinuses. So whenever you are in the lamina, probably you have some, thinking to remove the cells over the lamina. I like using the straight curette, going from posterior to anterior. There are different ways to do it, but this is the way I like myself. And then also, whenever you are on the skull base, you can also use the straight curette from posterior to anterior along the skull base to remove, just to check some of the septations over there, and then the curved curette for the frontal sinus around the sinus. And that's it.
I just want to talk something not in this table. This table really, it is with so many very beautiful instruments, and also very beautiful talks have been done a while ago. I want to tell you something that you will find it in your hospitals that you came from, which is the navigation technology, which I'm sure that is available in most of the hospitals, and also it will be available in our demo upstairs. and it cannot be come here in front of you, so that just I want to talk something about it. This technology is newly introduced in the field of otolaryngology and also in neurosurgery long time before. And this technology is very good to show you the vital structure and dangerous area. It's good for the beginner to train and to give them some confidence and to go more. But it should be also well calibrated. First of all, I'll tell you some basic of it. You should calibrate it with very, with the radiologist, and to have certain cuts of about 1 millimeter, and some of the radiology department, they have very good slices. They can give you even to 0.65 millimeter slices, less than 1 millimeter cuts. And then you have to collaborate it in your patient prior to the surgery. After that, you can use the incubator properly, and it is give you, as I told you, some of the confidence to see the vital structure. And sometimes if there is a recurrence case or a current case, or there is a difficult case, mainly in our area we have so many disease of allergic fungus sinusitis, and you find the walls of the base of the skull, walls of the lamina papyracea have been gone. And just we will show you today maybe, or tomorrow, or maybe in the advance, you will see this technology. You can come and ask the instructor about it, and if you have any question in between, we can just show you how it can be used, how it can be calibrated, and where is the most important area that you should be aware and use this incubator. And also use your anatomy and your skills, clinical skills, not to depend on this technology, and maybe will do a fatal mistake. Thank you very much.
If you allow me, I'll just add 2 points. Now, for any beginner who's doing sinus surgery, there is 2 major rules to keep it in mind. Number 1, don't depend on the board instrumentations, which is the shaver, because the shaver has a suction and eating up. Now, if you don't have a good map of the sinuses and you don't know where you are as a beginner, even for the expertise guys, you may end up in the orbit or in the brain, or you may end up with a major catastrophe. Always use non-board instrumentations, either to use a forceps or through cutting. Number 2, don't hold a bone or tropically or just air cells and just pull it out, cut and take out. Because pulling out, you may injure the skull base or the lamina papyracea, and you don't know what's behind that. Thank you.
Just don't cut a big thick bone with this, or the rep's not going to be happy with you.
Thank you.
It will break.
Thank you. We come back to the lectures. There is 2 more small lectures.